So welcome to the next session. I'm Hans Kirkeby from University of Aarhus in Denmark. So the next session is a very exciting one. It's a competition between trainee research programs, and we have 8 in total, and there's a competition between these 8. And after their presentation, Annette Fenner from Nature Reviews of Urology will choose the best of them. And that's going to be very exciting. She will make her decision out from the content, the way of presentation, and even if you are able to stick to the time schedule. So you'll have 6 minutes. So after 5 minutes, each of the speaker would see a raised arm from Gitte here, and then you know you have 1 minute left. And there will be no presentation between the speakers, so I will welcome Mette Schmidt to come here, and afterwards the next one with an interval of 6 minutes. So Mette, welcome.
Well, my name is Mette Schmidt, and I'm from Herlev Hospital. And thank you for the opportunity to present results from my study on delivering physical activity recommendation in daily clinical prostate cancer care. So exercise for men exercise has demonstrated improvements in physical function for men with prostate cancer. It reduced fatigue and improved quality of life. However, men with prostate cancer report one of the highest declines in physical activity levels after receiving a cancer diagnosis, and majority of the men do not participate in regular exercise. So physical activity promotion from clinicians during consultations has been identified as a supportive factor for engaging cancer patients in physical activity. But studies shows that retrospective studies exploring the delivery of recommendations from clinicians have shown that it does not happen routinely. So to provide suggestions for improving the delivery of physical activity recommendation, an observational interview study was carried out in 2 urological outpatient clinics. One of the outpatient clinics was our own at Herlev Hospital. Here, an exercise program has been implemented as standard of care for men prescribed androgen deprivation therapy. And this program also includes nurse-led follow-up consultation that supports the program. The other outpatient clinic was located in the southwest of Denmark. This outpatient clinic has participated in a trial that have explored community-based soccer for men with prostate cancer. The aim of my study was to explore how the delivery of physical activity recommendations was related to care practices in the daily clinical work. So the findings, just a little bit about my methods first, sorry. So the observations included consultation facilitated by a physician and supported by a nurse. And it also included a consultation that was facilitated by specialized nurses. The nurse-led follow-up consultations that supported the exercise program at Herlev Hospital was also observed, and interviews were conducted with both physicians and nurses. So the findings. So I found that the delivery of physical activity recommendations were related to 4 care practices. Firstly, like any other information during a consultation, information about physical activity was adjusted to match the need and the situation of the patient. This happened particularly in the initial phase, where clinicians commonly held off or only provided small amounts of information about physical activity in order not to overwhelm the patient with too much information. Providing too much information at the wrong time was viewed as conflicting with good patient care. Secondly, information and recommendation about physical activity were specifically provided when the patient experienced treatment-related side effects. Here, the recommendations gained value as a solution to mitigate current side effects or to meet the anticipated side effects and to help ensure ongoing treatment. So, thirdly, the information and recommendation about physical activity was, during consultation, was delivered as oral information only, except during the nurse-led follow-up consultations that supported the exercise program at Herlev Hospital. Here, a link between treatment-related side effects, physical activity, and health was formalized by incorporating a quality of life questionnaire and physiological measurements, such as hip measurements and weight. And this introduced what I have called visual aids and quantifiable data into the talk about physical activity. And the value attached to the use of visual aids and quantifiable data was explanatory and had value as something concrete to talk to the patient about. Finally, both physician and nurses kind of prioritized maintaining a good relationship with the patient over the delivery of physical activity recommendations if these recommendations was challenged by the patient. In these situations, the recommendations were adjusting according to the patient's objection, or they were not provided at all. So in conclusion, the delivery of physical activity recommendation might be improved by developing strategies that center the recommendation around treatment and its side effects, together with the inclusion of visual aids and quantifiable data to support the talk about physical activity. These strategies must take into consideration the clinician's priority of maintaining a good relationship with their patients. Thank you.
Hi everyone, my name is Alex Zhu. I'm a fourth-year resident here at the University of Michigan. I'm really excited to present our research on the use of a wearable physical activity tracker to track the perioperative activity of radical cystectomy patients. We all know that radical cystectomy is a very morbid procedure with high rates of readmission, complications, and mortality. To combat these adverse outcomes, providers frequently recommend patients to increase the amount of physical activity as well as their amount of sleep. However, there have been no studies that have looked at objective data on how much physical activity and sleep that patients receive in the radical cystectomy perioperative period. This data is really important though. We really need to know what the patient's recovery timeline is going to look like. Patients frequently ask us, hey doctor, when am I going to be able to exercise again? When can I play with my grandkids or start golfing or walk up the stairs again? When am I going to feel back to my baseline? Right now, we give answers based off our own clinical experience and our judgment, but we don't have objective data to back up our recommendations. For this reason, we wanted to find objective data, and we specifically wanted to know how much physical activity and sleep are radical cystectomy patients receiving in the perioperative period. What we did is we had patients wear a wearable physical activity monitor to track physical activity and sleep from baseline to postoperative day 90 after radical cystectomy. We told patients to wear their physical activity monitor for 7 consecutive days at 4 separate time points: at time of enrollment, after completing a 4-week exercise rehabilitation program, at post-op day 30, and finally at post-op day 90. This is a prospective single-center multi-surgeon study and included patients greater than 60 years old with radical cystectomy. We ultimately had 42 patients included in our cohort who wore their physical activity monitor for an average of 23.5 hours per day. Our first finding was that there was no difference in the amount of light exercise performed throughout the perioperative period. We define light exercise as metabolic equivalents between 1.5 and 3. These include activities of daily living such as cooking, making the bed, washing the dishes, and so on and so forth. This is a figure that we use to explain how much daily activity patients had throughout the perioperative period. On the y-axis is a number of minutes of activity performed per day. On the x-axis is the period. And at the top line is the amount of light activities performed per day. The middle line is moderate activities, and the bottom line is vigorous activities. As you can see by the top line, there really is no clinically indicative difference, as well as statistically significant difference in the amount of light activities performed throughout the perioperative period. What this suggests to us is that patients really are able to perform the activities of daily living even by post-op day 30 as well as post-op day 90. This is really important information to tell our patients when planning for their recovery, and then it allows patients to understand that even at post-op day 30, they'll be able to be relatively self-sufficient and will be able to perform the physical activity required to take care of themselves. Our second finding was that there was a big drop-off in moderate intensity exercise at post-op day 30. We define moderate intensity exercise as metabolic equivalents between 3 and 6 and include things such as brisk walking, vacuuming, mowing the lawn, and golfing. As you can see here, we had a big drop-off in moderate intensity exercise from about 60 minutes per day to 30 minutes per day at post-op day 30, accounting for almost a 50% drop-off. This finding made us think about this. Why are we having such a big drop-off in moderate intensity exercise? What can we do to curtail this? Although, as expected, a lot of this decrease in activity was likely due to postoperative debilitation fatigue, we couldn't help but think, are there things that we can be doing to combat this? And one of the things we came up with is we should be more explicit in terms of recommending activity guidelines to our patients. Just like a physical trainer tells their client, you should exercise for X amount of minutes and do these types of exercises, or a physical therapist does the same thing with their patients. I think urologists can do a lot and improve in this capacity by explicitly prescribing 45 minutes a day of low impact, moderate intensity exercises in the first 30 postoperative days. Our third finding was that there's no difference in physical activity at post-op day 90 compared to baseline. As you can see here, for light, moderate, and vigorous activities, there was no difference when comparing post-op day 90 to baseline. What this suggested to us is that physical recovery after cystectomy takes approximately 90 days. This is really important information that can really help patient counseling and allow patients to help judge how their own recovery is progressing. Now let's switch topics and talk quickly about our sleep findings. What we found was there's no difference in the amount of sleep hours or sleep interruptions patients had throughout the perioperative period. Sleep hours are on top and sleep interruptions are on the bottom. However, we did find that patients had a high number of sleep interruptions both before and after surgery, between 2.5 to 3.2 interruptions per night. Just to put this in perspective of the general population, only about 15 to 30% of the general population wakes up this much. So the implications of this are that bladder cancer patients frequently have many sleep interruptions. We should really focus.
Your time is done. You have to.
Okay. All right. So in conclusion, we provide the first study using a physical activity monitor to track physical activity and sleep in the radical cystectomy perioperative period. These were our main findings. We're excited to provide the first objective data that really can help patients understand their postoperative recovery timeline better, which should hopefully improve patient expectations and the patient experience. Thank you.
Hello everyone, my name is Frederick and I'm very grateful to be here to present our study entitled Opioid Consumption, Experience of Pain and Satisfaction with Pain Management After Robot-Assisted Radical Prostatectomy, USA versus Denmark. And this study was undertaken as the opioid epidemic has been a major problem in the States for several years by now, and we have not been able to observe the same thing occur in Europe. And this was also discussed at the 2017 CopMich conference, where it became apparent there that there existed major differences in pain management protocols. And so we undertook this study with the objective to compare analgesia consumption, experience of pain, and satisfaction with pain management. Our aim was to include 50 patients from the States and from Denmark undergoing a radical prostatectomy. This enrollment was done in Denmark in 2018 and in 2019 to 2020 in the States. And in 2020, February, a policy change was instituted at the University of Michigan, which completely removed opioids from the standard pain management, which ultimately meant that we had two groups for the United States, those before the policy change and those after. The exclusion criteria for this study include any preoperative pain, clinical T-staging above or at CT3A, performance status over 1, analgesia allergies, prior history of opioid abuse, and regular use of opioids. Postoperatively, patients were excluded if they had a claviculae complication grade of over 3. And so what we did with them was that we followed the patients for 1 week after surgery. For the day before surgery, we gave them the pain expectation questionnaire, which was constructed by the project group. This was done to evaluate potential cultural differences between the Danish and American group. And it was meant to assess attitudes towards pain and pain management. We, of course, recorded all analgesia consumption for the first post-operative week. We also gave the patients the questionnaire, the brief pain inventory short form, which is a questionnaire centered around the use of a numeric rating scale in order to rate experience of pain. And finally, we asked the patients on post-operative day 7, were you satisfied with the pain management you received? And this is the table 1 for the study. Overall, disease characteristics were more or less comparable. I might just want to highlight some differences in age. The Danish group was a bit older, BMI was a bit higher for the States, and comorbidities was also observed more readily for the American patients. When we look at the pain expectation questionnaire, overall, not that many differences exist. One can mention, number 1, I'm concerned with experiencing pain, where it seemed more American patients were more concerned. And I also want to highlight number 6, which is a statement that says, I do not want to receive opioids, where patients had to agree or disagree, where significantly more American patients agreed with the statement. And here it could be speculated whether or not more opioid awareness in the States caused this result. And moving on to analgesia consumption and opioid consumption, this was converted into morphine sulfate equivalents. And in Denmark, for the first post-operative week, a median of 15 milligrams was consumed for the Danish group, where this was 37.5 MSE for the American group, which was a significant difference. But if you look at before and after this policy change, which completely removed opioids for the American group, before this was 45 milligrams MSE, but after it was 0. So here it could also be speculated that patients will in general consume the medication they are prescribed, just in general, because we did not find any significant difference in acetaminophen and ibuprofen consumption. We also did not find any post-operative pain differences when rated on this validated questionnaire. And finally, satisfaction with pain management was overall very, very high, both for the American and the Danish group, and also when compared before and after this policy change. So to conclude, treating post-operative pain after a radical prostatectomy seems feasible with low amount of opioid use, and this could be done without compromising safety and still with patients being satisfied with the treatment they underwent. So thank you for your attention.
Good afternoon, everyone. I'm Kathy Nam. I'm one of the fourth-year residents here at Michigan, and thank you for the opportunity for us to discuss our work on opioid prescriptions before and after implementing a novel quality incentive for opioid-free vasectomies. There's been, So there's been increasing awareness of the opioid crisis in the U.S. In the recent decades, with about a third of these overdose deaths being due to opioid prescriptions. And because opioid epidemic is a multifaceted issue, there's been multiple levels of interventions to address the issue at hand. One example is an opioid-sparing perioperative pathway developed by the Michigan Opioid Prescribing Engagement Network, or MOPEN, that was developed in August of 2018. And at the same time, Blue Cross Blue Shield of Michigan instituted a Modifier 22 incentivizing this, where they allow for additional reimbursement for services substantially greater than what's required, which is up to 35% additional reimbursement to kind of acknowledge the additional work that goes into counseling patients through the perioperative opioid-sparing course. And the modifier 22 was expanded to include vasectomy on July 1st of 2019, and vasectomy was a perfect target because it takes place about 500,000 times a year in the US. And they also found in a survey in 2017 that about half of the urologists prescribe opioids postoperatively after a vasectomy. So with this in mind, what we wanted to do was to look at the perioperative opioid fill rate pre and post implementation of this novel quality incentive of the modifier 22 mechanism for opioid-free vasectomy that was deployed statewide in Michigan on July 1st of 2019. We looked at the administrative claims from Blue Cross Blue Shield of Michigan and included men between the ages of 20 to 64 who underwent procedures from February 1st, 2018 to November 16th in 2020. And we excluded those that required an inpatient stay, underwent concomitant procedures, or other operations within 3 days of the vasectomy, and without continuous insurance enrollment from February 2018 to November 2020, and with an out-of-state urologist. And we had two groups. The exposure group included those who underwent in-office vasectomy, whereas the non-exposure group underwent other urologic procedures in the office, including circumcision, cystoscopy, prostate biopsy, and transurethral destruction of prostate tissue. And the modifier 22 was instituted in July 1st of 2019. And what we did was we looked at the opioid fill rate for both the exposure and the non-exposure group, both before and after implementation of the modifier 22 mechanism, with 2 months of washout before and after. And this is the graph looking at the initial opioid fill rate for both the exposure and non-exposure group. On the y-axis, we have the initial fill rate, opioid fill rate, and then on the x-axis we have the month at which the patient underwent the procedure. And on the top we have the policy change of the modifier 22 that was instituted on July 1st of 2019. And in the middle we have grayed out 2 months pre and post that date for the washout period. The black line corresponds to the exposure group who underwent in-office vasectomy, whereas the non-exposure group or the in-office procedure group is represented in the gray line. And what we found was in the vasectomy group, we found a significant decrease of the perioperative initial opioid fill rate of 12.8%, which was not seen in the office procedure control group. So what this meant was for every 3 opioid prescriptions that were filled before the modifier 22, only 1 was filled after the modifier 22 was instituted, which led to a decrease of 8,473 oxycodone 5 milligram pills that were in the community in the post-implementation period. But before we talk about the implications of our study, I want to go through the limitations. Our data does come from a single state of Michigan, and we did only look at the adults that are insured by Blue Cross Blue Shield of Michigan, which is about 50% of our adult commercial insurance population. And we also did an interrupted time series, which inherently assumes that no other event happened at the same time that could affect the outcomes. And then because we're only looking at the administrative claims, we do not have information on the pain levels of the patients, nor the opioid consumption, nor the additional stresses on the healthcare system, such as phone calls or ED or unplanned clinic visits. That being said, these limitations notwithstanding, our study has important implications for providers, payers, policymakers, and patients. Although there's been multiple policy changes encouraging careful opioid prescriptions, this is a novel preventative strategy to incentivize physicians to rapidly decrease the rate of opioid fills following vasectomy. And this has further implications by decreasing the supply in the community for diversion. In the interim, our paper has been accepted to urology, and the modifier 22 incentive has actually been terminated statewide at the end of 2021. So we're planning on doing a follow-up study looking at the perioperative opioid prescription fill rate pre- and post-termination of this novel quality incentive. And from a policy perspective, these findings highlight the opportunity for the modifier 22 policy incentive to be applied to other states and other procedures as well. Thank you for the opportunity, and I'll be taking questions later. Thank you.
Yeah, so hello, my name is Alexander, and I'm from Herlev Hospital, and thank you to the committee for the opportunity to present some of the results from the study that we conducted at Herlev Hospital, titled "Can Intraoperative Nerve Monitoring Improve Functional Outcome After Robotic-Assisted Radical Prostatectomy?" So just to give some brief context, we already had a prostate cancer section, but it's a lot of people, it's a lot of new cases. In 2020, it was approximately 1.4 million new cases, the majority of which have localized prostate cancer at the time of diagnosis. And one of the most common treatments for localized prostate cancer is the radical prostatectomy. This is a treatment that, especially within the last 20 years, has developed a lot with the introduction of the robotic-assisted surgery method. But nevertheless, two major adverse effects still lurk in the background. That's incontinence and erectile dysfunction, both of which can have detrimental impact on patients' quality of life. So when it comes to the mechanisms of incontinence, we don't know as much as we probably do about the mechanisms of erectile dysfunction after prostatectomy. There are some preoperative biological factors, especially higher age at time of diagnosis, pre-existing lower urinary tract symptoms as well, and also higher BMI. And then there are some surgical alterations that we do during surgery. We alter some of the supportive structures. The quality of the anastomosis has a lot to say, and then also if there is any damage to the external urethral sphincter. And then one more possible factor in this mechanism could be damage to the nerves that innervate the external urethral sphincter. And these are somatic nerve fibers that branch out from the pudendal nerve. They run laterally to the cavernous nerves, but still in a relatively close proximity to the apex of the prostate, especially where they can be located between 1.3 centimeters to 0.3 centimeters from the apex. And as they are somatic nerve fibers, we are able to locate them during surgery if we use a nerve monitoring system intraoperatively, where two electrodes are placed in the external urethral sphincter during surgery, and then the Maryland forceps can convey an electric impulse to nerves, and if they innervate the external urethral sphincter, we should be able to see an EMG confirming their location during surgery. Now, we wanted to test if the use of this intraoperative nerve monitoring during unilateral or non-nerve-sparing surgery, this is where we're the furthest away from the cavernous nerves, can help prevent damage to the nerve that innervate the external urethral sphincter, and if this has a positive impact on functional outcome. So we set up a clinical randomized trial. We include patients from 2018 towards 2022, and they had to be scheduled for a unilateral or non-nerve-sparing radical prostatectomy, and they also had to be continent before surgery. This was defined as a score of 0 on the International Consultation on Incontinence questionnaire. The exclusion criteria were previous radiation to the pelvic region, previous trauma to the pelvic region, and also previous TURP, or if they had any comorbidities with known impact on neuronal function, especially erectile function and continence. So we calculated a population size of 88, and then we included 100 men to include for dropout. And the primary outcome was difference in ICIQ score at 12 months. The follow-up time was 12 months in total. And then we had some secondary outcome which looked at the difference in continence. This was defined as either a 24-hour pad test of 0 or a daily use of no pads. And then difference in potency as well. This was based on an EHS score. And then there was difference in IEF-5 score, which also takes into account the sexual activity of the patient. We also have some data still coming in that have not yet been analyzed. We excluded 126 patients during screening, and then we allocated the rest of the 100 patients. And then we had a dropout of 9 patients and a subsequent exclusion from final analysis of another 9 patients. Our main results, I would like to say first off that all the patients that we used nerve monitoring on, we found the nerves prior to removal of the prostate. But after 12 months, there was no significant difference in the ICIQ score between the two groups. The graph shows also that there are overlapping confidence intervals. And when it came to the secondary outcome, the results were the same. There was no real significant difference in any of the secondary outcomes that we have found as of yet. So the conclusion for now must be that identification of the somatic nerve fibers that innervate the external urethral sphincter did not lead to improved functional outcome compared to standard robotic-assisted radical prostatectomy. Thank you.
Good afternoon, everyone. My name is Parth. I'm one of the urology residents here at the University of Michigan. It's my pleasure to share our project on how spatial transcriptomic profiling of prostate cancer revealed zone-specific androgen receptor signaling and immune infiltration. I have no disclosures. So when we look at prostate cancer, especially prostate cancer that arises in the transition zone when compared to the peripheral zone, a couple of clinical characteristics that differentiate the two have arisen and been identified. Transition zone tumors have been noticed to tend to have higher PSAs, while peripheral zone tumors and patients with peripheral zone tumors tend to have poorer outcomes when compared to patients with transition zone tumors. The current treatment approach for prostate cancer is zone independent, and so better understanding the biology of zone-specific prostate cancer has the potential to change how we diagnose and treat prostate cancer. Our current understanding of the molecular difference between transition zone and peripheral zone prostate cancer is fairly limited. There have been a few studies that have looked at how the overexpression of proto-oncogenes ERG or ETV1 are higher expressed in peripheral zone tumors compared to transition zone tumors, or how there's an increased incidence of P10 loss, which is a tumor suppressor gene, in peripheral zone tumors compared to transition zone tumors. However, no study has really looked at the genetic difference between transition zone and peripheral zone tumors in space, as well as the difference in immune infiltration between the two tumors. And then some studies have looked at non-malignant tissue, and interestingly have found that androgen response signaling is upregulated in benign peripheral zone tissues when compared to benign transition zone tissues. And so we started off by identifying 3 patients at the University of Michigan who had undergone a radical prostatectomy. We had their prostate specimens. We had 1 patient with a peripheral zone only tumor, 1 patient with a transition zone only tumor, and then 1 patient who had 2 distinct tumors, 1 tumor in the peripheral zone and 1 tumor in the transition zone. We were able to identify multiple regions of interests from both peripheral zone and transition zone tumors using H&E slides and immunofluorescence stain slides. And then we performed digital spatial profiling and mRNA sequencing on these specimens. After that, we were able to perform differential gene expression to identify genes that are overexpressed or underexpressed, pathway analyses to identify signaling pathways that are upregulated or downregulated, and cybersort time to identify immune infiltration using genetic signatures for immune cells that had infiltrated the tissues themselves. Our region of interest selection started off by looking at the H&E slides, and the clinical characteristics of our patients are up there for your reference. We then combined that with immunofluorescence stain slides, which had been stained for DNA, pan-CK, CD45, and SMA, and we identified about 7 to 8 regions of interest within which we were able to narrow it down to 12 areas of interest. And so our first finding was that androgen response was upregulated in transition zone cancers when compared to peripheral zone tumors, and this was true in both the stroma of the transition zone as well as the epithelium of the transition zone. Additionally, this finding held true in all of our patients that had tumors in peripheral zones or transition zones when we compared only grade 4 tumors and when we compared the tumor within the same patient, suggesting that this may be grade independent, may be patient independent. We also were able to look at stromal versus epithelial expression of androgen response and found that across the board, it was overexpressed in the epithelia compared to the stroma, suggesting that this may be a cancer-driven phenomenon rather than a phenomenon of the environment of the stroma or the tissue itself. Next, we were able to look at cybersort time data to identify immune cell infiltration within the tumors themselves, and we found that there was higher T and B cell infiltration in peripheral zone tumors. This was only true when we looked at the entire cohort and our grade 4 only tumors. This finding was not seen in our tumors that had been isolated from the same patient. And the last finding we were able to identify from our data was that there was an underexpression of about 16 genes consistently across the board in peripheral zone tumors. And when we looked at that data, when we looked at those genes back at TCGA data with survival outcomes, we found that about 6 of them were associated with poorer survival when they're underexpressed. And this may explain why peripheral zone tumors tend to have poorer outcomes when compared to transition zone tumors. So in conclusion, androgen response is upregulated in transition zone tumors, which may explain why transition zone tumors tend to have higher PSAs when compared to peripheral zone tumors. This was grade independent and patient independent, and it was enriched in the epithelium and not the stroma, suggesting that this may be a cancer-driven phenomenon. Peripheral zone tumors tend to experience higher infiltration of T and B cells, and underexpression of specific genes in the peripheral zones are known to be associated with worse survival, which may explain why patients with peripheral zone tumors tend to have poor outcomes when compared to patients with transition zone tumors. Our study is limited. We only had 3 patients, and so future studies can look to increase that sample size. We have the opportunity here to add additional patients of African American descent, patients with normal prostates, and also looking at the normal prostate tissues in patients that have cancer. And we actually have a study going on with that that's funded by my resident research grant that I've been able to obtain from the department. Thanks.
All right, good afternoon, everyone. My name is Christian, and I'm from Herlev Hospital in Denmark. And first, I would like to take the opportunity on behalf of the CopMich planning team to extend my gratitude towards the Department of Urology at the University of Michigan, and in particular to the Nesbit board for the honor of having this joint CopMich and Nesbit meeting. This is truly fantastic, so we are very grateful for that. So prepubertal boys facing gonadotoxic cancer therapy do not have mature spermatozoa in their testes, and it is therefore not possible to cryopreserve these mature spermatozoa. Instead, they do have spermatogonial stem cells in their prepubertal testicular tissue, and this can be extracted and cryopreserved. And the idea is that this is performed before the boy initiates the gonadotoxic cancer therapy, and then when the boy is cured for his cancer, grows up, and one day wants children of his own, then this tissue that was cryopreserved in his childhood can be used to restore his fertility. The tissue cryopreservation process is illustrated here, and in the bottom you can see 3 different methods for fertility restoration using the cryopreserved testis tissue. One is to quite simply thaw the tissue and engraft it into the same patient when he's an adult, for instance underneath the scrotal skin. Another method is to isolate and propagate the spermatogonial stem cells, so you get a lot of them and try to inject them, for instance, into the radial testis to get spermatogenesis. A final method is you can try to mature the cells in vitro to generate mature spermatozoa that can be used for assisted reproduction. Importantly, all of these methods are still experimental. In 2019, a study was published in Science that demonstrated how you can take prepubertal rhesus macaque monkey testis tissue, extract it, cryopreserve it, and then engraft it into the same monkey at a later time where it was able to produce mature sperm cells, and these sperm cells were used to create the offspring baby Grady, as you can see here. So to further develop this method of fertility restoration, we wanted to try to do this in a human model. In a previous trial, we collected testis biopsies from men with non-obstructive azoospermia, and these were cryopreserved in a very large biobank. So the patient was a man with non-obstructive azoospermia who had his tissue extracted during a microdissection testicular sperm extraction, and approximately 1 year later, he came in and we engrafted the tissue in surgically created pockets under the scrotal skin, as you can see in the pictures here. We followed the man afterwards for 6 months with ultrasound investigation and hormonal assessment, and here are just some of the results that we can see where we demonstrated blood flow in the engrafted testis tissue pieces. After 6 months, we extracted the tissue, all of it, and obviously the first thing we did was to look for mature sperm, because that was really what we wanted to see. Unfortunately, we did not see mature spermatozoa, but when analyzing the tissue with histology and immunohistochemical methods, we were able to show both spermatogonia and Sertoli cells, and importantly, we were able to demonstrate graft survival 6 months after transplantation. So it's not the result that we really wanted, but it is a result that is encouraging towards this method becoming clinically applicable when today's childhood cancer survivors grow up and want children of their own. Now, as mentioned, we did not see mature spermatozoa, but the man had non-obstructive azoospermia to begin with, so it might be due to inherent spermatogenic failure. But we do not know this for sure, so obviously we're going to try to evolve this even further. We want to do future autotransplantation also in individuals who have normal testicular tissue. And we've been so fortunate to receive funding from the Danish National Independent Research Foundation to continue our studies. And this is also together with Professor Ole. So in a true CopMich spirit, we would try to also isolate these human spermatogonial stem cells, propagate them, and do radar test as injection experiments and also maturation experiments in vitro, so that hopefully we will get clinically proven methods for fertility restoration that can benefit childhood cancer survivors in the future. Thank you.
All right. So I'm Christian Sensland. I'm a urologic oncology and health services research fellow from the University of Michigan. Thank you all for your attention. One of the other Christians presenting today. So I have no conflicts of interest other than that the work I'm going to present today has funding from the National Cancer Institute. So today I'm talking about clinical trials, and I think clinical trials are fascinating in a lot of different ways. And we're going to talk about some of our approaches to improving the conduct and efficiency of clinical trials themselves, and so studying the science of clinical trials and our approaches to trying to make that actual science and that approach to our clinical trials really grounded in theory and in a way that we can talk about a shared common vocabulary and ways to improve our clinical trials. But first we need to understand why these clinical trials are important, and some of our past work will talk about this. So we know that clinical trials are highly important for underlying our guidelines, for advancing treatments for patients, and really form the final common pathway for a lot of the research that we see today and then going on into future years. But clinical trials themselves are very difficult to run, and anyone who's been involved in one will be able to tell you that, of course. However, there's really limited evidence on how best to design, run a trial, or then how to improve one that's struggling, which we'll talk about. And so we are going to propose today that implementation science is perfectly suited to addressing this problem. So we know that clinical trials are critically important. As I mentioned, they're a key pathway for advancing care. They can also be considered the highest level of evidence, but they also have benefits to individual participants. So if you enroll on a trial, you can expect standard of care or an experimental treatment which has a good chance of being better. And just from being on the infrastructure of a trial, you may receive better care than outside of a trial itself. And for some conditions like cancer, this treatment is so good on these that it can be the standard of care, including this statement in all of the NCCN guidelines for patients with cancer. And as a result of this, over $50 billion a year is invested annually into clinical trials around the world. However, clinical trials often fail, and some of our work has shown that about 1 in 5 cancer clinical trials fails to reach its anticipated endpoint, and so all that enrollment and effort is wasted. And thousands of patients are enrolled onto cancer clinical trials every year that ultimately fail. And enrollment is really the critical problem behind this. We took a look at clinicaltrials.gov and worked up an algorithm to figure out how many patients are actually enrolling onto trials. And we found that half of all clinical trials in genitourinary cancer fail to meet 85% of their goal enrollment, which is sort of a benchmark for adequate enrollment for studies. And even trials that are marked as completed, about a third will not meet their enrollment goals, which brings into question their power to answer the questions they sought out to answer. However, there's a real big clinical trials knowledge gap in that you might say, well, let's just make it better. Let's fix our enrollment. But where do we turn to in order to have those data? And there are really few studies of enrollment improvement, and the few that exist aren't rigorous, and they're not easily reproduced in the current way. Little evidence really underlies how trials are designed and implemented, so there's really a lack of integrated frameworks to approach this, which leads to our work applying implementation science here. And our argument is, as we've just gone over, clinical trials have major benefits, but they frequently fail, and there's a major knowledge gap in how to improve trials. So really what we're framing this here is that clinical trials are complex evidence-based practices that are suffering from poor implementation. And the reason we want to frame it this way is that then we can consider it in the same vein as other evidence-based interventions like smoking cessation or COVID vaccines, for example, where the science itself is really good, and the trick is getting people to actually do them. So the science of clinical trials is good, we just have to figure out how to get people to actually enroll on them and improve that through scientific approaches. And so implementation science tries to get people to do these evidence-based practices. And so we propose using these context-specific behavior change methods to assess the different contexts where we're running clinical trials and then figure out how to get people to actually engage with them in a better way. So for example, let's say that we're running a phase 3 prostate cancer clinical trial and enrollment is slower than expected. What should we do? There are really no evidence-based ways to assess how we do that. And so you might say, let's just hire some more trial coordinators, or let's send a new site invitation out, something like that. But we need a way to really rigorously identify how to do that. And so this is very quickly our approach to doing context-specific assessment and a better way that we think we can generate evidence for how to figure out what works for people. So poor enrollment to a trial could have multiple different reasons. For example, maybe there just aren't enough prostate cancer cases in our area, but maybe it's that our eligible patients aren't being identified. And through implementation science frameworks, which are listed above, I won't get into the details of that, but happy to discuss later, we may say that low local disease prevalence reflects poor trial feasibility. And this reflects a C4 domain of the outer setting, meaning out of our control as investigators. And one way to address this might be adding more trial sites. This also gives us a next step for how we can try to address that. And so we tried to do this of saying, is there actually a link between success of clinical trials and how many prostate cancer cases there are? We merged a couple of databases together and found that indeed trials in areas with lower prostate cancer incidence fail more often. We also linked this and mapped it. So if you were planning a clinical trial of prostate cancer, you could click on this map in different areas. So if I were running a prostate cancer clinical trial in Michigan, I would say, where are there lots of prostate cancer cases and few trials? And I would say up in Grand Traverse County, there are 81 cases of prostate cancer per year, but no trials. This might be a great area for me to set my trial in the future. However, if instead it's that eligible patients aren't being identified, this would be an issue of penetrating to the patients, a process problem, and perhaps instead I should work something up for an EPIC pop-up instead. Our ongoing work is trying to assess some of the clinical trials we have ongoing at the University of Michigan and around our state, and trying to find what has worked in the past so that we can link it to better evidence-based strategies that will work in the future, and developing informatics support in order to develop more of these interventions that might help us in the future. So in summary, clinical trials can be considered complex evidence-based interventions with significant benefits yet suffer from poor implementation, and we're going to apply implementation science to improve that in the future. Thank you so much for your attention.
So my name is Gitte Lam. I'm a urologist and head of the bladder cancer team at Herlev Hospital. I would like to thank all the presenters and ask you to come up here, and that we will have about 10-15 minutes for questions. Please come to the podium. I'll bring the green box if you have a question. Yeah, Dana?
Actually caught it. So in the 2 opioid trials, we know there's an opioid crisis in the U.S. and maybe not so much in Denmark with all the Vikings there that don't admit to having pain. But it seems as if Frederick, in your trial, they made a decision at Michigan to stop giving opioids. Kathy, they gave an incentive to physicians. They go, oh great, more money. Let's just say no. So effectively, the physician is saying no. You're not getting an opioid prescription. No, you're not getting an opioid prescription. Is it that simple to just stop the opioid crisis as far as a portion of it that is prescription driven? I mean, what if we just as physicians recognize there's a problem, just say no? Is it that simple? No on the prescription, no, to begin with.
I think one of the reasons why I found this study so interesting was when I started, no one at Michigan prescribes opioids after vasectomy. And so I was shocked to find out that on average, when we just look at the Michigan data, that on average, they were getting about 13 oxycodone pills, which is from us more than what a prostatectomy or cystectomy patient gets on post-op discharge. And so that was pretty shocking to me. But there have been multiple single-center studies that looked at what happens to patient satisfaction, what happens to the stresses on the ED and unplanned visits after they just switch over to non-opioid pain management. And what they found was that patients don't have a significant change in their pain satisfaction, and they also don't have additional stresses to unplanned visits and ED visits. And so I do think that, just in terms of us saying no and stopping the prescription at some point can have very extreme downstream consequences of A, minimizing the exposure of the patients to opioids in the first place, and then B, also decreasing the amount of opioids that are in community for diversion, because a lot of the community gets opioid prescription from other people who've gotten it for other indications.
A quick follow-up question for you, Kathy, actually. I was curious, did you see a difference? I think in your study, you clarified that you were looking at fill rates. Is there any literature, or did you see anything with regards to filled versus, prescription versus fill, and a difference in that?
Yeah, so we did also look at the prescription size itself, and what we found was before the modifier 22, on average, like I said, an average patient got about 13 oxycodone 5 milligram pills, or the opioid morphine equivalent of that, or the oral morphine equivalent of that. And then afterwards, it dropped to 3.5, which is still more than what we at Michigan prescribe. And then for the control group, which is for the patients who underwent the in-office cystoscopy, circumcision, and other procedures, what they found was that they were on average getting 11.5 pills of oxycodone 5 milligram pills, and then after the intervention, it was not a statistical difference, but it increased to 13. So there's a lot of opioids that are being prescribed following these in-office procedures.
So thanks for the presentation. So I want to direct to the two exercise presentations, my area of interest. My first question is, anytime you see an exercise study, I want to get excited and jump up and down. No pun intended. But the second thought is anyone going to carry this further? Is there a plan B here? So my question to both of you first is, what's next? And maybe for Alex, or maybe for both, my second question is, have you ever thought of tracking the partners? Because in the diet and exercise world, and Weight Watchers helped us find this, for example, they found that when one partner was becoming active or changing diet, in a variety of circumstances, the second partner came along, or sometimes provide the inspiration or non-inspiration to it. So that's my two-part question. One, what's plan B? And the second one is, have you thought about tracking partners in terms of physical activity, if it's a predictor of it or not?
Hi there. Thank you for those excellent questions. So the next steps for our project are, number one, to get this published and get this project completed. But the next steps after that, we've thought about expanding the project to other things, such as one of the limitations of our study was that we looked at a prior study and did a subgroup analysis, so all the patients had completed a 4-week prehabilitation program, so we really didn't have a control group. So next time we would want to have a control group, maybe one group that didn't have the exercise program, one group that just has a radical cystectomy, and we might be able to see the effects of physical activity after radical cystectomy. Other things that we'd want to look at are expanding this to a multi-institutional study. I know there's a lot of different authors and different institutions out there that have been looking at prehabilitation, as well as using tracking programs to see how patients are doing, and then potentially applying these physical activity trackers to other modalities, prostate cancer, bladder cancer, all throughout the field of urology. The other point that you bring up is very interesting as well. There's been a lot of qualitative studies that have looked at physical activity in the partner realm, and you're exactly right. Partners are a big part of if patients are motivated to exercise or not. A lot of the literature on exercise as well have shown that patients are frequently exercise more after surgery, because after they're diagnosed with bladder cancer and undergo a cystectomy, they have their aunts coming in to town, their uncles, their friends, their families, and that support group really motivates them to get healthy and exercise more.
Yes, well, the next step for my part will be to actually develop some of the strategies I suggested. And to the next question about the partners, I think it's very important with the context of the men who exercise. And I think I've did a study as well about men who had participated in an exercise program and, what supported they continued exercising. And peers, exercising with other men with prostate cancer actually facilitated the ongoing exercise. And I've also interviewed some of the men who have declined to participate in an exercise program. And for many of them, you know, if the partner or the wife was sick and they needed to be at home, that was actually kind of, you know, a point where they didn't want to exercise. So the context of the men's life is very important for their participating in exercise.
Yes, Alexander, I've got some specific questions for you. I've been treating incontinence, stress incontinence, as well as erectile dysfunction for many, many years after radical prostatectomy, and we've been working very much with identification of those nerves. So you're not able to show any difference between your two groups. But what is, can you put some more words on what's the way ahead? Is it totally impossible, or do you see any possibilities for the future? Are we able to make a reliable identification of the nerves in order to preserve them, or did we lose this battle?
Yeah, well, great question, Hans. Jan. Well, I want to say in terms of if we lost the battle of locating them, I don't think we did. One of the very difficult aspects of that, and I also I just mentioned it quickly, is that there's a big span of how far or close the nerves are located to the prostate, and actually when we've seen that if you do autopsies on infants, you find that they're relatively nice aligned and they follow a very neat pathway down to the external urethral sphincter. But when you do autopsies of elderly men, you find that they spread and fan out. So the most difficult aspect of that is if you can find anything that's where you can generalize across patients, and that's going to be very, very difficult. We also did actually try to take video of most of the surgeries, but it's really difficult to see if there is any pattern there that we can find for now. But one of the secondary outcomes that we also had was to see if there is any difference for the patients who had a change in EMG from before removal of the prostate and then to after removal of the prostate, to see if we could predict in any way those that would have a severe incontinence afterwards. We don't have that data yet, but that could also be one way of doing it. I mean, maybe we can't exclude, or maybe we can't find all the nerves, but maybe we can just find those who are going to suffer from severe incontinence. So I don't think we're completely giving up hope yet.
Thank you. I think we have time for one short question. Okay. Dana? Jens, okay, sorry.
Yes, so we should wrap up the session. Thank you for the presentation. Hello, my name is Jens Sørensen. I'm from University of Copenhagen, and I have the pleasure of introducing you to Annette Fenner. I will come back to you within two seconds. I would really like to express my sincere thanks also to all the young trainees, trainee projects. That's what I really can see is the heart of what we're doing together in CopMich and University of Michigan. And also from my heart, a deep felt thanks to Ganesh and the whole board team of the Nesbit Society, as well as the whole Department of Urology, for having us here. We are 25 from Denmark. We have never been so many. I'm very, very grateful for that. So thank you for this. So now, it's my honor and pleasure to welcome you, Annette Fenner, the chief editor of Nature Reviews in Urology. And I must say I have been knowing you for several years, a good friend. We have been seen also at the last meeting at CopMich. And you have been so kind also to come here to support the prize for the best presentation today. And I must also mention for all of you, and I think you agree with me, that it is very, very impressive what you have done with this review journal. The impact factor is now above 16, and we are talking within the specialty of urology. So please applause and welcome Annette Fenner.
Hi, everybody. I don't have any slides, which I'm really regretting right now, because I very stupidly said, well, I'll be fine, because I will work it out once I hear all the presentations. So I apologize in advance, because this is going to be very sketchy, and I'm kind of making it up as I go along. So, so first of all, I just really wanted to say thank you so much to Jens, to Dana, and to Christian for inviting me to join the CopMich meeting again. As Jens mentioned, we also, I came along to the CopMich meeting in Copenhagen in 2019, and I really think it's a fantastic collaboration and a fantastic concept, and something that really urology really needs and medicine needs. So thank you so much for having me. And Ganesh, thank you for allowing me to come and join you and for hosting me here in Ann Arbor as well. So I was going to do a bit of an intro to the journal, but Jens has kind of said everything I have to say. Yeah, I've been working on NIU for a long time, and we're very proud of what it does and what we do. And I hope you guys, if you don't read it, you might want to start. So on to the presentations. First of all, I would really like to thank everyone who did a presentation this afternoon. I think they really illustrate the bright future of our field, the breadth of research, the enthusiasm and the quality of research, and I think those are some of the things that make urology a really fantastic field, and I think we have a very bright future. So this was a horrible decision, and I would give a prize to everybody, which I realize kind of undermines the point. So many different topics, so many fantastic presentations. They were all brilliant, and there was pretty much nothing to choose between them. So in the end, I went for the one that kind of caught my imagination and I thought was really interesting, also some really beautiful images, and it really illustrated the importance of basic and translational research in urology, which I think has been really undervalued in the past. So the winner I picked is Parth Patel for his work on transcriptomics. You know where he is? Congratulations. Although it was a small study, I think it really laid the foundation for some really interesting stuff to come, and I'm really interested to see what you do with larger groups and different patient groups, so I think it was really cool. The prize is a one-year subscription to the journal, and which I'm sure you will very much enjoy. And a little certificate, which I don't have with me because I'm not that organized, but I will present it at some point later in the meeting. So I really hope you'll join me in a round of applause for all of the presentations, and in particular, Dr. Patel. We're going to take a picture.
Congratulate you. Thank you. Very nice. Thanks.
Can't get away that quickly.
Oh, really? God.
So I'm just going to add to this before we close the session today. Annette has been a great friend of CopMich, as has already been said a few times, but now you're a friend of the Nesbit in the University of Michigan Urology Department. So I'd like to present you with a certificate that has the Nesbit Society logo, the CopMich Society logo, and says University of Michigan Department of Urology, recognized with appreciation, Annette Fenner.
Thank you so much.
Should we take a picture of
Take a
everybody
picture.
here?
Take a picture.
Right.
All right.
Here we go.
Do you want me to hold up this?
Yeah.
We're so nerdy.
Closer?
Don't fall off the edge of Thank you.
Thanks. Was that the end?